yeah, so just some peds skin stuff. Some of this you're going to know very obviously. Some of it might be a little new. They close a PICU. Hopefully it's going to do All right. So piece number 1. 6-year-old male, fever and a rash. Very unique in your PCR. So fever for 3 days, cough and congestion. This morning, mom noticed a rash on his legs. Concerned or not concerned? Concerned. A little concerned. Also, look at the kid. The kid's running around with this is one thing, but this should always concern you. All right? Petechial rash. There's a bunch of them together. It's purpuric rash. So it's bleeding under the skin. Petechia, by definition, is less than 2 millimeters, but regardless of what it is, it's the same pathology. Your differential on petechiae in a child is about a dozen or 2 dozen different things. But history is very important. You know, the exam, yeah, he's got a non-blanching petechial rash, but history is important. The rest of the kid's physical exam is very important. Family history, what meds they're on, what meds are in the home that they could have crawled on the floor and eaten, how long he's had symptoms, what different symptoms he has. Rat poison. There's lots of rats in the city. There's lots of rat traps that landlords leave under the cabinets and don't tell families about when they move into the house. Dietary things. You know, you don't see a lot of vitamin K, vitamin C deficiency in the population, but there's also vitamin K, vitamin C deficiency disorders that can give you this bleeding issues. But fever and petechiae should always give you a red flag in your head that you should assume the worst and then be reassured if the kid's running, jumping around, eating, and doing other things. Alright, there's a now quite old study from Boston. They looked at bacteremia in infants with fever and petechiae. What's the likelihood that these kids are pretty sick? So they had 400 patients that had documented fever and a petechial rash. 2% of them had bacteremia. Of the well-appearing children, now this is a very squishy subject, but you know, it's harder to find ill-appearing. Well-appearing is fairly easy to find. A well-appearing child, none of these well-appearing childs had bacteremia. And they also found of these 411 patients, you know, of the 8 that had bacteremia, none of them had normal white counts. If they had a normal white count, none of them had bacteremia. But just be reassured that we see petechial rashes not uncommonly in pediatrics. They are well-appearing if they are running around. I don't say immediately give them Tylenol and send them out the door, but you can be reassured that you don't immediately have to tap and vancomycin them within the first hour. And this and other studies have led to some high risk factors that should lead you to think of tapping antibiotics sooner rather than later. Not well-appearing, ill-appearing. Obviously, anyone that comes in ill-appearing, they're going to do things sooner. Lethargy, irritability. Now, this is not to say if the parent says on their chief complaint to the nurse he's been lethargic, you immediately need to tap them. They use the word lethargic all the time. Med students use the word lethargic all the time. Residents use it all the time without really knowing what it means in the clinical exam. Petechiae below the nipple line or confluencing into purpuric rashes is a little more high risk than just scattered petechiae, especially in the upper half of the body. A too low or too high white count, obviously, and then any abnormalities in your PT-PTT would be more concerning. There's a little general flow chart. I think this is an up-to-date kind of algorithm for your general thought process on pediatrics with petechial rash. First thing, well-appearing, ill-appearing, fever, or no fever. And then you can go down the line. Is there a trauma? Is there concern for non-accidental trauma in this petechial rash? You know, septic child, coagulation issues. If they're not toxic appearing, not febrile, you can go down the, all right, other things going on, let's check some labs. Depending on your lab abnormalities on your CBC or your coags, you can go down and give yourself this, you know, narrow your differential a little bit. Case number 2. 4-year-old female, fever, rash, pain. Again, very rare. So she complained of fever and leg pains for her mom last night, gave her Motrin. Today she wakes up unwilling to bear weight. You know, not really wanting to walk. And this morning, mom noticed some hives on her legs and gave her some Benadryl. And then the hives didn't get better after the Benadryl, so she brought the girl into the ER. So, you talk mom more in your history, you realize that she's been treated twice in the last month for ear infections. She's on the last couple days of her second course of amoxicillin. And this is our rash. Any ideas? So, serum sickness. So it's a type 3 hypersensitivity reaction, and your key to this is, yes, fever, rash, arthralgias, but the timing is very important to discern your various things. So these antibodies form about a week or 2 after your initial antigen presentation, which in this case is usually antibiotics. And if you think, how long do we give antibiotics for these illnesses? 7 to 10 days. So commonly, the rash and the symptoms will show up towards the end or even after they're done with the antibiotics. Then you start getting this reaction. You get, and you know, it's often pruritic, but not always. Mucous membranes are not involved, which is an important, you know, differentiation. It can urticarial, serpentiginous, you know, it looks more like hives. Usually starts low and then spreads upwards. You know, fever, you can get polyarthralgias. They can get so bad that these little kids are unwilling to walk, limping, not wanting to bear weight. You can have some edema and lymphadenopathy with it. So you immediately stop whatever drug you're suspected to be on. Lots of times with the amoxicillin, they're either on their last day or they've completed 8 out of 10 days, and feel free to stop those last 2. It's usually supportive care, Motrin, Benadryl, you treat the symptoms. They have found some short-term steroids can help to reduce the inflammation and get the symptoms to leave a little quicker. You don't have to admit all of these kids. You admit them based on their symptoms. If they're refusing to walk and they're in a lot of pain and they're miserable, then admit them and you can, you know, hydrate them and give them medication. But if they're, you know, other than the rash and a little bit of pain that resolves after Motrin, if they're well appearing, feel free to send them home and they can follow up with their primary care doctor. Usually resolves within 2 weeks. Other things that aren't serum sickness. Viral xanthoms. We call a lot of things viral xanthoms. Some of them have actual diagnoses that we just kind of gloss over. I was talking to Joey about this yesterday. Worst case, you call something in a well-appearing kid a viral xanthum and it's something else that's also benign. Nothing bad's going to happen. You know, most of these benign little itchy rashes you treat symptomatically anyway, despite what their exact etiology is. But viral xanthoms, fever, rash, malaise, arthralgias, usually not as bad as, you know, you're not going to have a kid refusing to bear weight when they just have a benign viral rash. They can involve the pharynx and the mucosa. Lots of times, oh, he's got a rash on his arms and he's got a couple spots on his, Coxsackie, send him home. But it's not always, you know, the specific Coxsackie. We had one yesterday where had, you know, a couple of dots on his throat and had rash on the back of the hands and the arms, and the resident just saw hand, foot, and mouth, but nothing on the palms and soles, didn't really have, you know, an acute illness. So, but it's very easy to kind of just viral xanthum Coxsackie and send it home. You can have a hypersensitivity vasculitis, which is the same etiology, but, you know, history can kind of aim you in one direction or the other. Enoch-Schönlein is one of these hypersensitivity vasculitises. Acute rheumatic fever, despite some people thinking it doesn't exist anymore, it happens. And you get, you know, different kind of rashes. The erythema marginatum is a little different from your serum sickness rash, and you'll have a different history on it. Lyme disease, EM, scarlet fever can all give you fever, joint pains, and rash. So just, you know, very slight differences in what the rash looks like, your time course in the history. Something else that's you want to be aware of so that if it happens you recognize it. I've never had this, but just something to put in the back of your mind. So this is a dress syndrome. So very rare, but potentially life-threatening, drug-induced hypersensitivity reaction. It's usually 2 to 6 weeks after starting a medication. Anti-epileptics are more common than other drugs, but it can happen with antibiotics and other more benign medications. More common in adults. It's thought to be a reactivation of a herpes virus, can be involved in the process. But fever, malaise, rash, lymphadenopathy, again, you see this in everything, but this syndrome can give you this facial edema that's a little more pronounced. The rash starts, progresses into this is more later stage when all the rash kind of influences into just full-on plaques. Most cases involve more than half the body surface area. And you do have systematic involvement. You have elevated LFTs, you may have some V-ring creatinine issues, and you can have respiratory symptoms. Again, I've never seen this, but just something you see someone come in with this rash over half of the body, they're having all these other symptoms, a little something. Wrong direction. All right, 3-year-old male with a fever. Fever, cough symptoms for 6 days. Increasingly cranky, crying, refusing to eat. Today she noticed that his hands were a little swollen. Alright. This is what he looks like. What is this? We see this enough in peds. Not as much at Maimonides, I think because of the high Asian population. We saw it on a weekly basis. We don't see as much of it here, but still you get it a couple times a month. Fever for more than 5 days. Now this is always hard to tell because our patient population is not very good at history or measuring fever or knowing when their children has fever. But fever in your classic criteria are at least 4 of the 5. Conjunctivitis, non-purulent conjunctivitis usually. Mucous membrane changes, be it the strawberry tongue or the cracked lips. Anterior cervical lymphadenopathy. Polymorphous rash or red rash. At later stages, it can be a peeling rash, but usually when you diagnose this, it hasn't progressed to the peeling yet, so don't put your hat on peeling skin. And then hand and foot edema is usually, if you see that and there's kind of an other history, that's something that you notice, that's what sticks out to me the most when these kids come in with hands and feet that are more round than flat. As the years go by, less and less of these kids will have your classic criteria, and then you'll have to go down the road of atypical Kawasaki, where it would involve lab values. Sterile pyuria in the urine, inflammatory markers, thrombocytosis, increased white count, low albumin, although I don't really see that much, and then LFT elevations. And because there's such common atypical issue, there's an algorithm for, all right, he doesn't fit classic, but I still have concerns, and this brings you down to your kind of how you go through it. So basically your laboratory values. If the inflammatory markers are normal and it doesn't fit classical criteria, you can be a little more assured that you can follow as an outpatient, keep an eye on it. This is not follow next week. This is see your pediatrician in the next 24 to 36 hours. If the CRP is going to, again, you think about it, if a kid's had illness and fever for more than 5 days, it's unlikely that his CRP is going to be 0, whether he has Kawasaki or not. So I end up in this, I'm always here. I'm always in this box. And that box is get an echo and confirm if you have any coronary artery aneurysm. Usually where I train, the echo will tell you that whether you're going to treat or not. Here, I do this, I admit them for an echo the next morning, and the pediatric admission note always blows me off and says doesn't fit quality, and they usually go home with that. Yes?
I thought the coronary aneurysm was longer term.
It is longer term complication, but your echo you will see some issues. I don't know the exact, but there will be abnormalities on the echo. They're not going to have coronary artery aneurysms at the time of presentation. That is a late complication, but there will be changes on the echo that you will notice. So I know that where I trained, when we were in between, we were on the fence. the cardiologist would do an echo, and their their interpretation of what the echo looked like would kind of push us whether we're going to treat or whether we're going to watch for another day or two before treating. But if you're uncertain about this, then if you're clinically concerned and he doesn't fit the criteria and you're kind of in between, I'd rather you admit the kid, get an echo, have him watch him overnight, repeat the labs the next day, than just, hopefully it's not, we'll send him home and hopefully he follows up with the pediatrician. Your treatment is IVIG and aspirin. You give high-dose aspirin for a couple days and they're on low-dose aspirin for a while after discharge.
Should we start doing the ED with aspirin or anything?
No. I mean, if it's a classic case and you fit your criteria, then you can start the aspirin and the IVIG, absolutely. Or if you're in between and you're not certain of it, 4 to 6 hour delay for the floor team to start it is not going to do anything great. 15-year-old fever and rash. Fever, flu-like symptoms for 2 days, red, painful rashes, blisters in the mouth. She has epilepsy. She switched from Keppra to Dilantin last month. I'm sure you see this a lot more in adults, I feel, than in kids. But here's a rash. There you go. So the last time I looked at it, it's thought that the EM, Stevens-Johnson's, toxic epidermal are all kind of on the same general spectrum, and it's just a measure of severity and additional symptoms. You consider the body surface area. They all have this kind of prodrome of fever and flu-like symptoms before your mucocutaneous symptoms develop. You guys know this, so I'm not going to spend too much time on it, but just be aware that mucosal doesn't just mean the mouth and the lips. You can have conjunctival changes in the eyes. Urethritis is a mucosal surface, and tracheobronchitis, which is a little more rare, but mucosa isn't just the mouth, just to be aware of. Medications, lots of times your classic is anti-epileptics, but there's all sorts of medications. Antibiotics, the sulfa drugs and the penicillins are more commonly caustic than cephalosporins. Drug exposure about 1 to 3 weeks before, but it's not exact. If you are secondarily re-exposed, it can happen a lot quicker, and not necessarily the 1 to 3 weeks. At a certain point, you treat these like burn patients. You put them in a burn unit, fluids and nutrition optimization, wound care, eye care if they have any eye involvement. Stevens-Johnson syndrome is a little more benign, that if you catch it, you treat it, you're good. Once you have toxic epidermal, the mortality spikes a bit. But again, you don't see this too often in pediatrics. I'm sure you guys see it more. 12-year-old female, fever, body aches, and rash. All these, same chief complaint for all of them. Symptoms started this morning. She woke up, body aches, she's got a rash all over, she's miserable, hurts everywhere. And then, mom kept her home. And then in the afternoon, she developed belly pain and vomiting. And that's what her rash looks like. So, now your hint here is to give it away. If you do a proper history, when's your last menstrual period? Started 2 or 3 days ago. She's 12, so she's new at this. She doesn't know how it works. Alright. So, Staph aureus, your common is, you put the tampon in, you leave it in too long, and your staph toxin starts to do it worse. Incidence used to be much higher, but thankfully to education, whatever you think about the sex education in this country, at least there's some sort of tampon education. You can't leave it in for a week. There's also non-menstrual causes, so you can't just hang it up on, she changed her tampon twice a day. It can't be toxic shock syndrome. Post-surgical, postpartum, osteomyelitis, pretty much anything that you have staph, that, staph can cause an exotoxin anywhere, so you have to just keep your mind open that it's not always the menstrual products. But anything with MRSA infections can technically be the MRSA that gives you the exotoxin and can cause toxic shock syndrome. But fever, hypotension is a good sign that this is not just your typical fever and rash. You must have 3 or more systems involved, be it GI, muscular, mucosal, renal, liver, hematologic, or CNS. Your treatment is to remove the offending agents, cure, if it's not a tampon, take care of the offending infection if it's osteomyelitis or something else, sinusitis, foreign body in the nose can do this to you. If you have a kid with, usually it's the organic porous substances, tissue paper in the nose can do this. If they put a little thing and you get a, purulent MRSA sinusitis, can give you toxic shock syndrome. Supportive care and antibiotics to treat it. And I had one girl in St. Louis, she got it once, I think from a sinusitis, and she was a weird girl, and she just had recurrence. And every time maybe twice a year, she would just get this recurrent toxic shock syndrome. And she would be in the NICU for weeks at a time. It didn't make any sense. All right, what else is caused by staph, or sometimes strep, where you get red, painful skin? This you see a little more often. They're not all this extreme, but it's basically, looks like a bad sunburn, painful to the touch, usually has some desquamation, but not always. So you can have some facial swelling, you can have some crusting around the mouth with this. Your classic sign is the Nikolsky sign, where you just gently stroke the skin and it gives you this desquamation, the top layer of the skin sloughs off. But cover for staph, supportive care, usually is inpatient supportive care. At this point, they're pretty miserable. They don't want to move, they don't want to eat, so they need fluids, pain control until you get kind of over the hump there. I'm not going to spend too much time on this. They don't always have a sandpaper rash, but fever, sore throat, rash. There's your rash. Now, in our albino population, you don't really see this classic, red splotchy sandpaper. So you have to use your tactile senses a little more than in other populations. But, the dry rash, and it feels like sandpaper because the papules are classically 1 to 2 millimeters. So you don't get, the larger macular papular rash. They're smaller spots. This is a blanching rash. Usually starts at the top and moves down. No palms, no soles. And then past Tia's lines, the rash is more prominent within the skin folds, but again, that's more of a textbook finding than your classic finding that I don't see any past Tia's lines. They must not have it. Group A strep, again, it's the only thing that you do low dose amoxicillin for. Everything else gets high dose. You see this mistake a lot. And then regardless of how you feel about rheumatic fever, different people think it exists or doesn't exist, but I like to treat strep to prevent rheumatic fever. Another thing with strep in general, lots of kids in the population that get strep, this kind of young school age, they don't necessarily present with a sore throat. They won't complain of throat pain, but they will often be belly pain, vomiting, headache. So, I swab more often than not, even if they're not specifically complaining of sore throat, if they have, this fever, belly pain, vomiting, just because I found that belly pain and vomiting with the URI symptoms is strep more often than I think it is. So, a 7-year-old male in the picture, but 7-year-old male with painful blisters around the mouth, fever, poor appetite for a few days. Now is this? It can be. The next pictures will be more obvious, but this, looks like a gingivostomatitis. Now, most of them are herpetic in nature, whether it's real HSV or not. But, so this, it could be hand, foot, mouth. It could be something more severe. Should have put one of the other pictures on this page. But if you see that progressing to this, that's not your classic hand, foot, mouth. This is more of a herpetic gingivostomatitis, and the HSV gingivostomatitis just gives you, it can have more complications. It can progress more rapidly, more extensively than just your Coxsackie hand, foot, and mouth. Usually you don't see this like confluence of vesicles in hand, foot, and mouth that you do. You can, but usually the HSV gingivostomatitis will present more severe like this. Your complications that you worry about, the herpetic whitlow on the fingers. Lots of times the fingers are misdiagnosed as paronychia cellulitis abscess, but you just have to be careful. If you see vesicles and there's other signs, other history, even they're not always classically vesicles. The herpetic whitlow can present as pustules, and they may look like they have white pus in them, and they look more like scattered abscesses on the fingers, but they can be HSV, can present more pustular on the hands. Or if they have eczema, you can get, HSV super infections of pre-existing eczema. When you have an eczema flare, you have skin breakdown, and it's an opportunity for other mechanisms to invade and cause a super infection. Oral versus IV acyclovir. It depends on what the kid looks like. If the kid needs admission or isn't that severe, it can be followed as an outpatient. 7-year-old female, raised rash on the legs, joint pain, getting worse for the last few days. Today is also complaining of abdominal pain. Anyone thoughts on this? You guys know your book stuff. So, IgA vasculitis, palpable purpura, again. This is one of the classic signs that you do see more often than not, but again, it's not always there. Usually a transient migratory arthritis. They don't always have abdominal pain, but if they do, that's very helpful in sending you in the right direction. This abdominal pain can have edema that can be a lead point for intussusception. So just be aware of that. Just keep that in your mind. Renal involvement, and renal involvement usually is a good predictor of severity. If these kids, I always check a UA and a comp and BUN creatinine in these kids to see whether or not there's kidney involvement. If there's no kidney involvement and they're fine other than some aches and some pains, then they can be followed as an outpatient. There is kidney involvement, depending on the severity. I usually run it by renal, and I found that they're more inclined to admit than discharge for these kids. But treatment, supportive care, steroids, and then depending on the degree of renal involvement, you have the renal specialist follow up whether they need more, intensive kidney issues. A couple more. You see this a lot. I see this a lot here than I have anywhere else, especially in the last 2 months. So rash per week, mostly on our abdomen and our back, bubbles that pop and then erode. It's tough. It's specific to get a history because the patient that I remember had this. All of her lesions looked like the picture on the right. And you walk in and you just have no idea what's going on. And then the mom says, oh yeah, they didn't start like that. They were little bubbles. And they were yellow and fluid came out. And then in the next day, they all turned into these raised, crusted, ulcerated lesions.
Like it's another type of staph, basically.
Think similar. Bullous impetigo. And it looks creepy, but I had a run of these a couple weeks ago. I think I had 3 in the same week. And one of them we called derm for because it was the daytime, and they were very cranky. Oh, this classic bullous impetigo. How dare you call us on this case? So, most common age is 3 to 10. It's most commonly in the torso, but it can be in the extremities and on the upper neck. Staph that produces this exfoliated toxin A, and your cell physiology is there. Epidermis. I found that derm likes to treat it topical and oral. topical Bactroban on these ulcerated crusted lesions, and then oral either Keflex or Bactrim. I like Bactrim, and they usually are okay with just Keflex. Now there's a more ulcerative form of impetigo on the spectrum, which is ecthema, and these lesions will extend deeper into the skin layers. They're going to present more as punched out ulcers, that bottom picture, with raised margins, but again, just oral and topical treatment. Oral female, itchy bumps, arms, butt, and legs. URI symptoms off and on for the last month or so, and then a week after she got over her last cold, she just developed this rash. Went to her primary care, viral xanthum, here's some Benadryl, sent her home. It's been 2 weeks since that, it's been a month since that. Child's still very itchy, the rash is not going away. URI symptoms and the fever are long gone, but this rash is just persistent. The rest of your exam is normal, but that's what you see on the rash. Any ideas? No, it's the whole body. No dermatomas. You don't see it that often. You see it more in peds than, I've never seen it in an adult, but these little kids will get it a lot. And you'll get this sudden eruption all over the body, these usually quite itchy lesions. The school will freak out and send them home. They're usually flesh-colored, flat-topped, no central umbilication, and they're usually very, very itchy. These kids are miserable, just going to town. They can coalesce into plaques, but usually it's these just diffuse, scattered papules. They don't really know what causes it or how it develops. The theory is that they found, on the studies they have done, about 1/3 to half of them have EBV titers positive. But in the third world, it's more associated with hepatitis B. Here it's more viral EBV, and the others are like adenovirus, rhinovirus, kind of your miscellaneous viral etiologies. Excellent prognosis, nothing bad's going to happen, but they last forever. And it's just a source of misery for the patient and their families. 10 days to up to 6 months. No studies have found steroids, either steroid cream or oral, to be helpful in any way, so it's just supportive care, antihistamines, calamine lotion, and reassurance that one day it'll get better.
Do you do both, like H2 and?
You can. I mean, the more recent studies that I've looked at said that the Zantac is less and less believed to have strong evidence for it, so it's not going to hurt, but I think the more that comes out is that, it's thought that adding the ranitidine onto it would be helpful, and now they're kind of wishy-washy on whether it actually helps or not. Last one, second to last one. Fever, full body rash for full days. Oh, never mind. No fever.